So I will
Yes,
be
sir,
just
visible.
going through the graphs and curves, which is again one of the most important domain in any exam, and that also applies to the addictive exam. Now, what are the normal graphs and curves that we are expecting in any critical care exit exam? First and foremost is the ventilatory graphics. Again, it is not the graphs only. They would ask you, they would show you some intervention and some maneuvers, and you have to identify what is the maneuver being done, what is the intervention that has been done, and what is the result of that. So that can be one of the domain. Then ETCO2, there would be some or other troubleshooting in the capnograph. I'm not going into detail in this session. Then CBP, PA catheterization, invasive blood pressure, IABP. Now, IABP has been already discussed in detail by Dr. Jitendra. Invasive blood pressure, PA catheterization, CBP. Though we may not use it in every patient, but the examiner's gold standard question related to cardiac output is from PA catheter or invasive blood pressure, the advanced cardiac output monitoring. And again, CBP though is out of fashion now, but yes, to understand the physiology of our critical care hemodynamics, we need to understand CBP. So that's why the examiner may ask you some or other troubleshooting in the CBP, PA catheterization, IBP. Now ICP, intracranial pressure waveform, is again a hot domain. We would have one of the conceptual video on this ICP. So please stay tuned. If you are registering, you will get this video again week after week. You will get some of these videos would be based on this ventilatory graphics or ITCO2 or ICP. Now TEG and ROTEM again we have covered today. So two important domains have been discussed today already, and the third one I would be discussing now in next 15 to 20 minutes. Now, the question format related to ventilator graphics or any of the graphs and curves would be revolving around four question patterns. Identify the problem, cause, solution, trials, if any. Okay. So right now, these are the something which you need to understand. Now, troubleshooting means you have to open up the problem, like the thing that is there in your the your home or in your learning process, like this AC. You have to clean up, and then you have to start functioning. In case you are unable to do it, don't shoot that. So that would be something very pathetic, and the examiner would be inside this the system. So don't try this type of thing, otherwise you would be losing your edic, and also the examiner would not be alive to take the next candidate's exam. Okay, so then the ventilatory graphics, I would be only coming to the the main highlights, because we do not have much time. Rather, we can discuss it in in our subsequent conceptual videos. But in summary, the problem can be divided into something like this: high peak inspiratory pressure, normal plateau pressure. Now, in these situations, it would be mainly the differential diagnosis would be the airway obstruction. Airway obstruction can happen due to tubing problem, bronchospasm, and secretions. These are the three common things that can happen in our ICU practice. And as per the problem, you have to opt for the solution, like check for the kinks, nebulizations, suction, all these things would be there. Now, there would be another situation where your peak inspiratory pressure would be also high and your plateau pressure would be high. In this situation, what is the problem? It would be along with the ARDS, there is the compliance problem. There may be also mainstem intubation, pneumothorax, obesity, distension due to the abdominal pressure is rising. So all these things would be the differential diagnosis. Now, as per the problem, you have to opt for maybe bronchoscopy you have to do, maybe chest X-ray, maybe bowel preparation, or maybe you have to go for the if it is the abdominal distension, you have to put a NG tube, you have to congest that. Now, octopip, it would be something which question would be something which would be important in our ICU practice. Obstructive lung disease, insufficient expiratory time. So this would be something which is sometimes very commonly asked in the your ICU exit exam. Now, how you are going to deal with the octopip? We all know. Maybe it is dynamic hyperinflation. Maybe it is obstructive airway disease that has to be taken care by decreasing the PEEP by 2/3 to reduce the auto PEEP. You can use the bronchodilators, you can use the steroids, you can decrease the I ratio, you can increase the inspiratory flow rate, you can decrease the respiratory rate. So these are the something which we all know we have to troubleshoot in your exam. Now hypoxemia, if your patient is suddenly having hypoxemia, maybe you can do with the ventilator issues, there is something happening, maybe pneumothorax, maybe alveolar filling, then maybe there would be pulmonary embolism, and along with the problem you have to opt for the solution. Now how the patient is actually fighting with the ventilator, whether it is due to pain, anxiety, or is there any dysynchrony happening, that you have to look at the ventilator setting, look at the patient, look at the monitor, and then you have to treat the overall problem. Now, I would be sharing with you 10 questions. It would be quick, rapid, but I will not wait for the answer because yes, we are actually right now almost 3.5 hours. Could you please read the picture and elaborate what is happening? This is the question. In examination, you will get this type of ventilator graphics. So you have to just immediately find out where is the problem. I would be now giving you the answer. This is a volume control ventilation. Why? We all know, because here the flow is the square pattern and here the pressure is actually rising in this type of the shark fin fashion. Now shark fin fashion is something which is we do not want. It has to be smooth waveform. Now why it is volume control ventilation? I have already told. Square or constant inspiratory flow waveform, linear rise in the tidal volume, and progressive rise in airway pressure during inspiration. That you can all see in this one, progressive rise, right? Now, what is happening here? This is abnormally increasing. This should normally increase, but here it is abnormally increasing airway pressure during inspiration. What is happening because of that? The pressure waveform shows a marked upward ramping, and that is called as shark fin appearance. What do you mean by shark fin appearance? Here it is the shark fin appearance. It looks like exactly shark fin, right? And the significance of shark fin appearance is that maybe here the patient is having increased airway resistance. And most common causes are bronchospasm, secretions, mucus plugging, endotracheal tube kinking, water in ventilator tubing, and most important times, like sometimes we do is small endotracheal tube. Patient has been put on maybe adult male is on 6.5 number or 7 number, 7.5 number tube. That could be the prominent cause of increased airway resistance. Okay. Now, bedside approach, auscultate the lungs, pass suction catheter, check the T2 position and patency, inspect the ventilator circuit for any kink or any water deposit or condensate along the side of the tube. In case you are getting the bronchospasm, you will be immediately administering bronchodilator if you are suspecting bronchospasm. Now, the diagnosis in this graph was high peak inspiratory pressure due to airway resistance problem, mostly bronchospasm. Okay. Now, in exam, what will be like your answer? You can say pretty well. This is a volume control ventilation mode with a square inspiratory flow with a progressively rising pressure waveform that indicates my patient is having increasing airway resistance. And I would be starting to first read the bronchospasm, then the secretions or mucus plug, and third one would be to just check the tube size, tube is correctly placed or not, along with some or other circuit obstruction. It would be short, crisp, and a structured approach. So the examiner would be very keen to know how you are dealing with sudden ventilatory trouble that will be appearing in the patient. Okay. Now this is something, some of the conceptual thing. I'm not again going into detail. What do you mean by compliance? What do you mean by resistance? What do you mean by elastance? What is the trans airway pressure? What is the trans thoracic pressure? Then what is the trans respiratory pressure? What is the flow volume equation? Then how you will be dealing with the equation of motion of the respiratory system. Now the equation of the motion, again, some or other the things before entering into the ventilatory troubleshooting, you should know this is the composition of, or the two components are the ventilatory pressure and with the muscle pressure. And in that you can see the formula elastance into volume plus resistance into flow. Now I am not going into detail, but you should be again clear with what are the basic ventilatory modes based on the pressure control ventilation, volume control ventilation, how we are calculating the total like the pressure, elastic pressure, resistive pressure. Okay. Now, the second question, could you please explain each pressure color? This is a very favorite question. I think everybody knows it, but in examination, you should be very clear so that the answer should come immediately within 5 to 10 seconds from you. Now, how you are going to differentiate between these three types of like the pressure scalar, and I know you all like will be very clear. Their first one is high peak and normal plateau pressure. That is the resistance problem. Then high peak and high plateau, that is the compliance problem, and the last one is elevated baseline itself, so that is the P problem. And how you are going to deal with this, I have already shown you in the 2 to 3 slides before. Now question number 3, you are in the ICU as attending and your trainee has done something and you immediately passed by that ventilator and you are actually looking at the ventilator screen, and you have to say in the examination what the trainee is actually trying to do here in ICU. Any smart answer? If I can just take 1 minute of your time. Anyone? Are you all with me? What the trainee is right now trying to do? Any answers? Anything? No answers? Okay. So now you have to follow certain principles. This the maneuver during a volume control breath. The trainee has actually manually extended the end inspiratory period by applying the inspiratory hold here, because the flow has been paused here. And this is seen as flow waveform returning to and remaining at zero flow at end inspiration. You can see here. I would show you. Yes. Now you can see the flow has actually reached at the zero level, and there has been pause. And you can see here what is the purpose of doing this procedure, why the trainee has done like this. The maneuver is performed to measure the plateau pressure and the static compliance. This is the fundamental principle behind doing the inspiratory hold or flow pause. Now, the clinical insight with this, the pressure waveform demonstrates here initial plateau followed by a sudden secondary pressure spike immediately before the exhalation. Where can you get this one? I am showing you. This is the inspiratory hold, but suddenly there is a secondary spike happening here. Okay. Now, what is the reason why this has actually happened? Now, I would explain you. This pattern suggests that the patient may have coughed or actively fought the ventilator during the inspiratory hold. Consequently, what happened? The recorded pressure peak or peak pressure that has risen markedly, approximately 50 centimeter water, despite you have actually reduced the peak to zero. Right. Now, this measured plateau pressure is unreliable. So in this, if you are getting the plateau pressure to be around 50, it is actually not the right the plateau pressure, because the patient has actually right now fought with the ventilator, and that's why the pressure is high. So it should be repeated under optimal patient ventilator synchrony. So this should be your answer. Now the exam pearl here, what you should answer in your exam if the question is straightforward, what the trainee is trying to do and what is your interpretation. This is an inspiratory hold maneuver that measures P plat and static compliance. Now I can see here a sudden pressure spike during the hold. Usually, most probably this patient is having a active effort, coughing, or there is a ventilator dysynchrony, making the measurement inaccurate. So I will not rely on this 50 centimeter water or the plateau pressure, which is too high for this patient. Rather, I would wait for the patient to be with a patient ventilator synchronous, so that I can again try to elicit the static compliance and the plateau pressure. Clear? Now, question number 4, a 76-year-old man with acute respiratory failure was mechanically ventilated on volume control ventilation. You noted the following curves and parameters on the ventilator display. What type of problem is present in the curves? What is the most probable cause? Anyone? Here I am dealing with gas trapping or auto PEEP. Now there is incomplete exhalation that is happening. Expiratory flow ongoing before a next breath, leading to air trapping and auto PEEP. Now in case your patient is having complete exhalation, so expiratory flow would be at the zero before the next breath is delivered. Clear? Now, there have been lot of causes due to the auto PEEP or dynamic hyperinflation or expiratory flow limitation. So now most likely cause is COPD or severe airflow obstruction. Along with that, there can be cause like severe asthma, high respiratory rate, short expiratory time, excessive tidal volume. How you are going to manage? You have to just reverse the problem, like decrease the respiratory rate, increase the inspiratory flow. As a result, what would happen? Your expiratory time would be prolonged. Reduce the tidal volume if it is appropriate. Treat with some or other bronchos like no dilators, steroids. Consider maybe external PEEP so that you can actually diffuse the increasing PEEP to certain extent. Now, example, failure of expiratory flow to reach the baseline before the next breath is equal to auto PEEP until proven otherwise. This is the mantra you have to remember for your exam, and also it applies to your clinical practice. Now, for the increasing PEEP, what is the maneuver you should do? This is expiratory hold maneuver. Now, inspiratory hold for P plat or static compliance, expiratory hold maneuver for to know what the auto PEEP, increasing PEEP, dynamic hyperinflation. Now, I'm not going into detail, but yes, this is you are actually the flow is seized during the in like no expiratory hold, expiratory time. So that is the principle. How you are going to perform the expiratory hold maneuver? The expiratory hold maneuver is exactly essentially a scenario where you are actually disabling the trigger for a while. Now you are holding down the button, there is no flow in the circuit, and the ventilator will not deliver another breath until you release. Now this maneuver allows your pressure from the hyperinflated alveoli to slowly pendule up around the respiratory circuit to be shared by all components. Now, in that way, what will happen? You can see what is the machine PEEP and what is the intrinsic PEEP. This is the principle. Question number 5. Please analyze and describe what is happening here. Any smart answers here? What is happening? Anyone? Please wear your thinking hats, though it is not appropriate at this time. But yes, what is happening? Here, this example shows total of 6 breaths. You can see here 1, 2, 3, 4, 5, 6. Now, all triggered by the patient's effort. You can see here, there is a slight deflection, negative pressure here. So, the patient is trying to take the breath. Now, PEEP is set at 5. Okay, PEEP is set at 5. Now, you can see breaths 1, 3, 4, and 5. They are spontaneous breaths because the patient is able to take the breath with a tidal volume of around 100 to 150 ml. It is less. But number 2 and number 6, they are intermittent mandatory breaths which are delivered with a decelerating flow setting and set tidal volume of 450 ml. That means whenever the patient is trying to breathe on the exactly mandatory breath, the ventilator is also supporting here and your target tidal volume of 450 ml is delivered. But in other areas, the patient is trying to breathe, but there is no mandatory breath which is actually supporting here. As a result, only 100 to 150 ml tidal volume is generated. Clear? Question number 6. Could you please tell the mode characteristics, indications, and contraindications? What is the mode here? What are the characteristics? What are the indications and contraindications? Now, here the mode is airway pressure release ventilation, APRV or bilabel. In exam, it is a hot favorite. So please read about the concept of APRV mode. What are the characteristic features? It is a time cycle pressure control mode with a two pressure level, P high and P low. What do you mean by P high? P high is for a long duration pressure will be maintained, and that is the majority of the cycle. Now P low is a brief release phase, where the pressure would be released and immediately there would be pressure high. Okay. Now spontaneous breathing is allowed at both pressure levels, and ventilation occurs during pressure release from P high to P low. As a result, what would happen? There would be alveolar recruitment while limiting the cyclic collapse. Now, indication for this APRV mode: moderate to severe ARDS, refractory hypoxemia despite conventional ventilation, patients who are benefiting from spontaneous breathing. Lung recruitment strategy: it is one of the rescue strategies, sometimes is helpful when you are unable to improve the oxygenation in a case of severe ARDS with high mean airway pressure, trauma, and post-operative respiratory failure. There are certain contraindications or cautions that you should remember. What are they? Severe obstructive airway disease, that is COPD or asthma, with autopip risk. If your patient is having raised ICP relative, you should not use APRV mode if it is not like that seriously indicated. Severe air leak syndrome, BPA for large pneumothorax, deeply sedated or paralyzed patient. So it would lose the spontaneous breathing advantage. Spontaneous breathing advantage is one of the key characteristics of APRV mode. Now, when the patient is deeply sedated or paralyzed, you are actually not getting any benefit of your mode. And again, significant hemodynamic instability. It would be not a good candidate for your APRV mode. Now, in exam, they would be expecting that APRV is equal to almost CPAP with brief release. Oxygenation determined mainly by here P high and T high, not P low, T low. And carbon dioxide is eliminated, but that would be determined mainly by release frequency and T low. So these are the two things that you should remember: how oxygenation is better here, how carbon dioxide is eliminated here. Okay, and what are the things that would be determining this oxygenation and carbon dioxide elimination or ventilation. Now, there are certain important things about this APRV mode. This was introduced by Stock and Down in 1987. It is relatively newer mode of ventilation, and this P high and T high, P low and T low, that you need to remember where oxygenation happens or recruitment happens, and where carbon dioxide removal or ventilation happens. That you need to understand. Then how you are actually changing or transition from the P high to P low, that would be also you need to remember. This is the inspiratory phase, this is the release phase. There is no such called as expiratory phase. In the release phase only you will get the ventilation which is happening. Okay, now T high, T low, I have already told how you are calculating the cycle or the uh, inflation deflation cycle. Again, 12 second is T high, T low is 3 second, 12 plus 3 is equal to 15 second. Now, this is one inflation deflation cycle that you need to remember. And in a minute, you are allowing 4 inflations and deflations that you need to remember. Now, if the patient has no spontaneous respiratory effort, APRV actually happening becoming typical to inverse ratio, pressure limited, time cycle assisted mechanical ventilation, just like a pressure control ventilation. Right. So you don't need to mug up this. Rather, it is one of the very innovative and physiologically sound ventilatory mode that you need to understand. Now, question number 7. Identify the problem and the solution. Here, what is happening? Here, the problem is secretions or condensate in the ET tube or ventilator circuit. Now, why you are getting the secretion condensation, how you are actually diagnosing? They are happening sawtooth oscillations on both pressure and flow waveform. You can see, right? This is sawtooth. Okay. And this is classic turbulent flow through this fluid. And volume returns to baseline. So that rules out leak. No abrupt pressure spike, that rules out mucous plug or kinked ET tube. And the key discriminator between this mucous plugging and leak is the sawtooth throughout inspiration and expiration. That is the key discriminator. Now, mucous plugging, if it is happening, so it can cause intermittent spike. It will not be throughout. And water in the circuit causes fine oscillation. So here secretions, it is not completely water. Water would be fine oscillation, not like the sawtooth or coarse oscillation. Now, what are the solutions? Aggressive oropharyngeal or ET tube suctioning. You can use saline lavage or if thick secretions are there. Check the heated humidifier. Empty all water trapped in the circuit. If you are using HME, just check whether that has been saturated or clogged. You can think of changing that. Maybe you need to do bronchoscopy if the secretions persist despite suctioning. So the clinical pearl here, this is a benign, like no fixable cause of alarm. Do not escalate sedation or change ventilator setting. Problem is in the airway, not the machine or the patient. Question number 8, identify the problem and what would be your intervention to solve it. What is happening here? Anyone? Okay. Now the diagnosis is here auto triggering. Ventilator is actually auto cycling. And what are the waveform clues? Multiple breaths are delivered without clear patient effort. Rapid, repetitive triggering and small baseline fluctuation preceding the breaths. Irregular respiratory rate and tidal volume and triggering occurring despite absence of a consistent inspiratory effort. Most likely, circuit leak is the most common. As a result, what is happening? There is pressure drop. Immediately, the ventilator is sensing that I need to trigger. The circuit is actually triggering the ventilator. Trigger sensitivity, set too sensitive. Water condensate in the circuit, that is actually doing the auto triggering. Cardiac oscillations are actually behaving like these are the small deflections that is due to the respiratory indrawing. Bronchopleural fistula or cough leak, the air leak is actually acting as the trigger, and external vibration or movement that is too sensitive that the ventilator is auto triggering. Okay, so auto cycling or auto triggering. What are the intervention? You can check the circuit ET2 for leaks, drain water from the ventilator tubing, reduce the trigger sensitivity, less sensitive, switch the trigger type, that is if it is flow, change to pressure. Now pressure, change to flow, check for a cardiac oscillation induced triggering and inspect if your patient is having some or other bronchopleural fistula. Now in the examination, auto triggering means ventilator delivers breaths without true patient inspiratory effort. But there would be a differentiating point with the double triggering. The examiner may ask you when you will be differentiating or how you are going to differentiate from the double trigger. Now auto triggering is no patient effort preceding the breaths, while double triggering is strong patient effort that causes two consecutive breaths. It will not be continuously like this. Okay, it would be two consecutive breath and the patient will breathe on his own, right? So one line answer in examination, the waveform demonstrates ventilator auto triggering most likely due to an overly sensitive trigger setting or circuit leak. Now I would be managing this patient, checking for the leaks, draining the condensate and reducing the trigger sensitivity. Okay. Now question number 9, identify the problem and the interventions to solve. What is happening? Now I think everybody would be answering this correct. This is double triggering, just what I discussed in the last the question. This is the result of ventilatory inspiratory time being shorter than the patient's inspiratory time, causing the incomplete patient effort of a first cycle to trigger a second ventilator breath. So ventilator inspiratory time is actually shorter than the patient's inspiratory time. The patient is continuing to take the inspiration, but the ventilator is thinking that yes, now I have to deliver the second breath. So double triggering is, this is when patient wants to take a breath with a longer inspiratory time than the ventilator setting. Okay. This can usually be improved by matching the patient's inspiratory demands better. Okay, by increasing the inspiratory time, increasing the tidal volume. Now, last question before we'll be concluding for the evening. A 64-year-old male with severe COPD is mechanically ventilated in volume control mode for an infectious exacerbation. Now, on morning round, he appears distressed, tachypneic, and using accessory muscles. The ventilatory settings show baseline rate of 12 breaths per minute, but his total rate fluctuates erratically. When you did the end expiratory flow maneuver, you are getting the increasing PEEP of 8 centimeter water. Okay. Now the bedside monitor that displays the waveform like this. Okay. Now what is happening here? There is something happening in between. So this is the increasing PEEP which is happening, and as a result, patient is having multiple independent patient efforts visible during the expiration, where the flow waveform shows a sudden upward deflection towards the baseline. But these efforts are actually failing to drop the airway pressure sufficiently to cross the trigger threshold. As a result, what is happening? The machine is completely failing to recognize the attempt. As a result, the delayed breath occurring, or there is no mechanical breath which is delivered. Now you can see here. Yeah, there is a deflection. This is trying to cross the baseline, but it is unable to actually initiate the breath, and the ventilator is unable to drag the air into the patient. Okay. Now, this is due to increasing PEEP or auto PEEP. Why this is happening? The air is trapped in the lungs. The patient must first generate enough negative muscular pressure to overcome this internal positive pressure before the ventilator can sense any change at the circuit level and then trigger a breath. Now, higher the increasing PEEP you will get, the harder the patient must work just to crack open the ventilatory valve. So the ventilator valve will not be opened till you are from the manual side is actually overcoming the increasing PEEP. How you are going to do the intervention? I'm just trying to give you how you have to first optimize the ventilator sensitivity. Again, then decrease the increasing PEEP. How you are going to decrease the increasing PEEP? By increasing the expiratory time. Decrease the set respiratory rate or increase the inspiratory flow rate to shorten the inspiratory time and prolong the expiratory time that I have already explained. And you have to administer some bronchodilators. Again, you can increase the external PEEP also just to overcome the increasing PEEP. Okay, so this is something to decrease the total amount of muscular effort the patient needs to exert to trigger the machine. Okay, this is something very important. This the increasing PEEP, then extrinsic PEEP, inspiratory hold, expiratory hold. The examination would be revolving around these basic ventilatory maneuvers interventions. Now, this is the differentiate between ineffective trigger and double trigger. Double trigger, 2 consecutive breaths. Ineffective breather, there would be deflections, but the patient will not be able to breathe on his or her own.